Can you hear me, Patrick?
I can hear you, Don. How are you doing?
Thank you. Good, good. Thanks.
We'll give everybody a couple more minutes to get in. Maybe they'll get disgusted by the score of the Dodger game and come join this training. And then we'll still win at the end.
Somebody said all you have to
We
do
have a lot
is
of,
watch the last.
we have some recommended practices and some
It's been
papers
true.
that are talking about.
I'm sorry, someone was speaking at the same time Judy was? Or,
Is
It was
talking
me,
about
my
with
husband's
the
making a
Montello simulation.
presentation.
okay. Yeah, you don't want to leave in the last 5 minutes of a Dodger game. That apparently is very much true. But I guess, yeah, you can just watch the last 5 minutes of the Dodger game too. Good idea. A lot of you are coming in through the Eventbrite link, and it's marking you as anonymous. So if you can browse or mouse over your rectangle, hit the dot, dot, dot in the top right, and then click rename. It'll give you the opportunity to rename yourself to something other than anonymous.
Okay.
You're good at Orlando.
Am I?
Yes.
Am I? Okay. Thanks.
All right. We'll give everybody one more minute
Okay.
and we'll get started. Well, it's better than 5-0. That would just be embarrassing. All right, thank you everybody for coming tonight. As stated earlier, someone scheduled a Dodger game at the same time that we're doing this presentation. So I appreciate that you're and acknowledge that you are probably watching the Dodger game and this at the same time. So we're all good with that. Hopefully they pull out of the current score. Thank you everybody for coming. My name is Patrick Botts Forbes. I am the LAFD CERT Central Bureau Coordinator and the Central Bureau Director for the Neighborhood Team Program. During a disaster, neighborhood disaster response teams will be doing whatever they need to do to help small emergencies from becoming life-threatening disasters. Most people will survive the earthquake. 99.99% of the people in this city, in this county, will survive the earthquake. What happens immediately after the earthquake will determine a lot of different things on how severe it is and how quickly that recovery occurs. And what we really want to do is put together neighborhood disaster response teams to help our neighbors get through it so they can recover faster and get through it so they don't have any complications that could be life-threatening or result in them having to go to the hospital or have their house explode because gas is leaking or whatever else might occur. And it's impossible to say what's going to occur. It's really going to be whatever needs to be done. Remember to move the live caption out of the way. So incident response teams are really going to be a jack of all trades. They're going to do whatever is needed to be done. They're going to do basic first aid. They're going to be taping off dangerous hazards. They're going to clear non-dangerous hazards. They might be doing traffic control. They're going to be a continuous triage and reassessment of their neighborhood. But what's important to remember is that it has to be within their skill set, within their training, and if they have the proper equipment to do so. We don't want to have a team out there that is cutting up trees using a chainsaw that they don't personally own and are not experienced using. That is dangerous, and will quite possibly lead to someone injuring themselves severely. We don't want to have people who are not medically trained doing first aid. So you really have to understand your skill set and what you bring to the table. And we hope that you're going to continuously try and improve, take additional training, get certified for first aid, take more advanced first aid. If you own a chainsaw, learn how to use it. If you don't own a chainsaw, maybe learn how to use one just in case you come across one. But the general understanding is that the person who owns the chainsaw will be using the chainsaw and not someone else. We don't want to take that risk. We don't want to use other people's equipment that we are not familiar with. And most importantly, and this is where we're lacking right now in fundamental understanding of what CERT is we really want to be a calming and visible presence, and really the uniform, people understand what a uniform is. And our uniform as community emergency response team is the green vest, the helmet, and the backpack. And if people know what that image is, and they see these people walking around their neighborhoods and they know they are their neighbors, but they've been trained by the fire department and they've gone through additional training and practiced and are experienced, that they are the first responders until the fire department arrives, that's going to reassure people that they're not alone when their entire world has just literally been shook by an earthquake. The ground has literally moved underneath them. Power's out, their cell phones don't work, 911 is ringing busy. And that's really where we want to get things to be, is that people know what the green vest and helmet and backpack mean. In 2019, 83% of LAFD calls were medically related. Be it I'm not feeling well, or I've got a scratch and I want somebody to put a Band-Aid on it, or I need to be taken to the emergency room because I'm suffering a cardiac arrest. Whatever it is, 83% of the calls in 2019 were medical. Those calls are not going to go away after the earthquake. In fact, they're probably going to get a lot worse. Most injuries that occur occur either during the earthquake or minutes after, and then an hour later as people start to clean up and become injured during the cleanup process. And by far, the number one injury from the Northridge earthquake was glass cut up feet. Because if you think about your home, most people don't wear shoes inside. They're either barefoot, they're wearing slippers, sandals, or they're wearing just socks. And you have a lot of stuff that is not bolted down that's going to fall off the walls, fall off the shelves, go flying across the room. The kitchen alone is a hazard ready to happen. And people are going to, parents especially, will be running over to check on their kids, and they're not going to care to put on shoes and make sure they don't step on broken glass in the hallway. Picture frames, for example, are going to fall off and break. Various things. You can think of the Legos. You've stepped on a Lego before, you know how painful that is. Imagine if it was broken glass. So what we're probably going to be doing is we're going to be bandaging a lot of feet. By dressing, cleaning those injuries, and bandaging them, we're going to reduce the chance of them getting infected and becoming a medical emergency. When we start talking about team size, the ideal numbers are, what we're teaching at least, 3, 5, and 7. You generally don't want a team, span of control is no more than 7, 5 being ideal. When you add that in, the team leader can then have a team of 7, but that means the even numbers can be broken up in unoptimal ways. So we like the odd numbers because it discourages you breaking up the team in an unsafe manner. The core of that team is going to be the leadership element. That's the team leader, the radio operator, and the scribe. Of any team, a damage response team, a damage assessment team, an incident response team, you're always going to have that core 3 people there, the team leader, the radio operator, and the scribe. And then you're going to have a response element on top of that on the incident response teams. And that's going to be pairs, either 2 or 4, bringing your total to either 5 or 7 from the 3. I hope that makes sense, basic math. Now, I ordered this in what I believe is actually the most important to the least important of the team. The scribe, I actually think, is a critical element, more critical than the team leader. If you have a good scribe on your team is going to excel because that scribe is documenting everything, and you're going to constantly be referring back to the scribe's documents and notes. They're going to keep track of incidents, radio calls, the time something came in, number of victims, severity of the injuries, and any actions that were taken. You're going to constantly be referring back to those notes. And if you don't have a good scribe, that's going to be problematic real fast. So if you think that a scribe is a menial position, I challenge you on that thought process. The radio communicator is essential to this team being able to go more than a block or 2 away from the staging area. If you don't have 2-way radio communications, you're going to rely on runners to go back and forth to staging and let them know what's going on and what resources you need. So a good radio communicator is going to be very effective at this team being out in the field. And then the team leader, of course, they are critical as well. They ensure that the team makes it home safely. They're a less active part sometimes in the team's function because they're not hands-on. They're there to make sure that you stay on mission and that everybody makes it home safely, but it's really the team members who do the job. And then, of course, what the team leader actually does is set the tone for the rest of the team. Their energy level is going to be critical. If they are jittery or they're worried, they're unconfident, that's going to trickle down to the entire team. The team leader has to be hands-off. If you have a team leader who goes hands-on, that team leader ceases to be the team leader. and suddenly no one is watching to make sure that everybody is safe, and your entire security model has just fallen apart at that point. For a medical response team, your team leader doesn't necessarily need to be medically trained. It's helpful, but the team leader's there to not do the job. They're there to make sure everyone gets home safely. So they don't have to be an EMT to be a team leader on an incident response or medical response team. Or the argument would, of course, be for a medical TARP team. You do want someone who's medically trained being at the top of that. But don't feel like you have to be an EMT to be in this role. Again, you're going to be setting the energy level and tone for the rest of the team. If this is your first time out after the earthquake and you've never been in an earthquake before, maybe don't be a team leader. Just because that lack of confidence is going to be very palpable for the rest of the team, unless you're good at faking it. If you're good at faking it, then by all means, sometimes you have to fake it to make it. But if you're calm and exude an aura of confidence, the entire team's going to pick up on that, and they're going to function a lot better than someone who is nervous and seems like they're worried that they're going to mess up at any given time. Most critical, of course, is the team leader makes sure the team makes it home safe. Everyone who leaves makes it home. That's the number one rule. And they're going to be working with the staging area to make decisions. The team is boots on the ground. They see what's going on. The staging area is blind. They have no idea what's happening in the field. However, staging does develop the big picture, and that's something that the team may not know. You might get into an argument with staging if you're the team leader saying, I need to work on this one patient right now because they're bleeding out. And staging is very much aware that there is a hazard that is moving through the area. And no, if you stay there and work on this person, you're going to get caught in that hazard, and possibly the team is not going to make it home. So it's not a challenge, but it's a partnership between the team leader and staging, making sure that there's symmetry, making sure that you're working together to accomplish the mission, which is help your neighbors and then make it home safely. You really want to establish roles and expectations at the very beginning. A lot of times you're going to join a team and you're going to want to get out there. If you're the team leader, you want to get in the field, you want to do some good, and everything is secondary to that. But if you build your foundation at the very beginning, you get to know everybody's name, make sure everybody knows who you are. You start addressing people by their name. You build a rapport with your team, and it's a much more cohesive team. It's able to work better. You have to know what everybody's abilities are, what everybody's capabilities, what everybody's concerns are. And if there's any limitations, physical limitations, or even mental limitations, if you have someone who has had post-traumatic stress and they're out there in the field, they may become a liability if they encounter something that triggers their PTSD. So understanding that ahead of time, you can actually circumnavigate a hazard if you see it coming up and you know that might trigger one of your people. When you give directions, you really want your team to confirm back verbally. You say, okay, we're going to go down to 5th Street, we're going to go over one block, and then we're going to come up Blue Street. You want that verbal repetition back. Okay, we're going to go down 5th Street, and then we're going to come up Blue Street, or was it Green Street, or was it Red Street? Make sure everybody's on the same page. Make sure everybody repeats back the same information so that everybody got it right. And this is going to save you a lot of problems down the road. Again, don't be too eager to get out in the field. Don't take too long, but don't rush it. Make sure everyone agrees on what everybody's doing. And then keep it calm, even tone, and pace. Don't yell at your people. Yes, we're all volunteers. Some of us may have a lot more experience than others. Some may have high pressure jobs where we're leading, 100,000 person companies and we have all this experience in the world, but we're all volunteers here. a volunteer can walk away at any given time. If you're getting frustrated with your volunteer, they're probably getting frustrated with you, and that can quickly go to, I don't want to say go to blows, but it can quickly go to yelling and screaming at each other. And then the team cohesiveness falls apart entirely and the team fails hardcore. So try and keep your ego in check and understand that everybody's here for the same reason. Everybody wants to help out. And whatever misunderstandings you have with your team, work it out together. Don't yell at each other. Just take a breath, take a step back and say, hey, we're not understanding each other. Let's figure this out so we can move through it and move together as a team. Your radio communicator primarily has to realize that they are proactively communicating with the staging area. They're not waiting to be told to communicate. If you're waiting for your team leader to tell you to call something in, you're taking too long to call it in. You see something go, a car flip over in front of you. Don't look at your team leader and wait to be told to call this in. You should be immediately pulling up the radio and going, staging, this is Alpha Team. Wait to be acknowledged. Staging, this is Alpha Team. We have a flipped over vehicle at the corner of Walk and Don't Walk. We're going to investigate. That is not something you need to be told, nor should you be told to do that. Now, maybe the team leader is going to go, hold on. Don't call us in just yet. And they might have a good reason for it. But this is your job to communicate. You're going to be providing location updates to staging. Staging only knows where you last radioed in from. And if you go 15 minutes, you could cover a lot of ground before radioing in, and they have no idea where you are. And suddenly something happens to you, and they only know the last location where you radioed in from. So you want to really communicate your location every time you take a turn. If you don't communicate with staging, every 15 minutes. So if you're on a long road, long straight stretch, you're not communicating back, it's gone 15 minutes, call in, let staging know where you are, update them. Without being told to do this, this is your job. Just talk to staging. You're providing situational awareness. So if you see something you think staging needs to know, talk to your team leader, say, hey, should I call this in? And then any updates to the incident. Staging is blind. Staging has no idea what's going on out there. You're providing that feedback. If something changes, let staging know. And again, don't wait to be told this. You know what's going on better than anyone else does. And maybe even if you are a little green and you need more experience, we do drills so that you can get a handle on this and understand this before the earthquake happens. Again, don't wait for the team leader to tell you to call staging. When you're talking to staging, when you're talking on the radio, we find that the 5W system is the best way to get your points across. If you follow this, you're going to be very effective on your radio communication. The first W, who are you trying to reach? The second W, who are you? You then wait to be acknowledged by net control, make sure someone's listening, or be acknowledged by staging, and then you start over again. Who are you? I'm sorry, who are you trying to reach? Who are you? Where are you? That's critical, because if your radio drops dead at that exact moment, at least staging knows where to find you. What do you have and what do you need? And those last two are a little optional, but generally you're going to be calling in with a piece of information. So what do you have? And then if you need something, what do you need? And you may not need anything. Maybe you're just providing situational awareness, or you're telling staging, we have this flipped over vehicle at Walk and Don't Walk. We need an incident number, and we're going to get back to you with that information. Ask for that incident number if they don't give it to you. An incident is something that you're going to possibly be able to respond to. If you have a 3-story building that's fully engulfed in flames, you may or may not get an incident number because there's very little you can do about that. We had a drill where somebody was asking about a dead body. I would not give an incident number for a dead body because there's nothing you can do about the dead body. You're literally going to leave it there. But you're going to call it in, let staging know that there's a dead body here. but it becomes a crime scene and there's nothing you can do about that. The scribe, again, I think is the most critical person on the team. They're actually an active role. You're not a passive person waiting to be told what to write down. You're documenting without being told to document. You're going to be keeping track of where are we? What, where did we see this? Where did this incident occur? The location is critical. Always be aware of your surroundings. Always be aware of where you are, because if you need to call in because suddenly something became extremely unsafe and you needed help, either you get attacked or there was an explosion and you're now lying on the ground and you're shell shocked, knowing that location is going to be critical to getting that information out in a timely fashion. So always be looking around as you're walking, and everyone on your team should be doing this. Okay, we're approaching the street sign that says walk. We're passing another street sign that says don't walk. This is Main Street. I see numbers on the ground, 225. Okay, we're at 225 North Main Street. That information, run that through your head periodically, because you never know when you're going to have to report that in a flash, and thinking about it or looking around for it at that time is just going to cost you time. When you're documenting, you want to document when you triage the number of survivors, gender, approximate age. And you could be wrong. Maybe, she's 30 and she looks 50, or maybe she's 50 and she looks 30. It doesn't matter. It's an approximate age. Just guess it if you don't have any confirmation on it. And then chief complaint. So you might document something like this: 5 victims or 5 survivors, 3 immediate, 35-year-old female, 20-year-old male, 15-year-old female, 2 delayed, 40-year-old male, 5 female. And you can abbreviate in your notes to make it simple and easy to do, just like it is on the screen. 5:3 immediate, 35F, 20M, 15F, 35-year-old female, 20-year-old male, 15-year-old female, 2 delayed, 40M, 5F, 5F, 30-year-old male, 5-year-old female. That's just ways you can do it in your notes. You're obviously going to be the one taking the notes, so however it works best for you. If you have a particularly medically trained staging area, the second line becomes a little bit important, because if I was staging manager, I would want to know details, because then I can triage in my head as well as an EMT. So I want to know that 35-year-old female is breathing rapidly. Immediate, too vague. Is she bleeding out? Is she having trouble breathing? Is she unconscious? I want more details. 35F, colon, rapid breathing. 20M, 20-year-old male, colon, unconscious. 15F, severe upper thigh lacerations, applied a tourniquet, or dash TQ. So when you're calling this in, or your radio operator is calling this in, and you have these notes jotted down, they can read it off of your notes as the scribe, and they don't have to think about it. You're an active pair with your radio operator. You're providing them the information they need to call in. They should also be taking their own notes, but some of us become radio operators because we have horrible penmanship. Again, you're going to be working closely with your radio operator. You want to anticipate what they need to say on the radio. This is why it's good for you to get radio training too, and cross-train with each other. Practice being a radio operator, practice being a scribe. You don't know which role you're going to be needed for, but if you're able to fill both roles, your leader is going to assign you to the most appropriate role. Anticipate that radio operator's need for communication. Jot down bullet points. Make it easy for them to read off. Anticipate the 5 W's. Who are they trying to reach? Who are you? Team Alpha, write it down. Or Alpha Team. Where are you? Quickly write down the location. You've been watching where you are, so you're keeping track of that. What do you have? 5 immediate, or 5 victims, 3 immediate, 35-year-old female, 20-year-old male, 15-year-old female, 2 delayed, 40-year-old male, 5-year-old female. And what do you need? Well, you probably need a medical response team at that point. If you're going to be doing medical, the working pair that becomes the working group needs to have a little more consideration than just a pair of people, a pair of responders. When you approach as a medical response element or team or pair, you want to have one person who's hands-on and one person who's hands-off. You don't want to overwhelm someone who's just gone through a major shock or is injured. If you swarm with 7 people on top of one person who's been injured, is confused, is having trouble and difficulty, and is in pain, you can send them into a spiral and make things a lot worse. So you really want to have that one person making contact. Your scribe, your hands-off person, is backed off a little bit. They're there taking notes, but the first person who's on them is the only person that's really engaging with the victim or survivor. You're going to, as the hands-on person, you're going to be assessing and treating. You will not, I repeat, you will not reach into your bag with bloody gloves on. You will contaminate everything in your bag. Your hands-off person, on the other hand, you're going to ask them for what you need. Hey, can you hand me the roller gauze? Can you hand me 4x4? Can you hand me a non-adherent pad? They're able to reach into the bag because their gloves are clean and not going to contaminate everything. This is why 2 people, one person hands-on, one person hands-off. That person's also scribing and possibly on the radio as well, communicating back to maybe a larger team. If you're on a medical response team, you want to adhere to what are called standard precautions. You want to make sure you establish body substance isolation, BSI. You're going to have personal protective equipment. If you don't have this and you don't get assigned it, you're not going to be a medical response team. It is not safe. You want to have medical gloves, preferably non-latex. Some people develop an allergy to latex. The general understanding is most people should have nitrile gloves. There are some people who are allergic to nitrile. Whatever works for you, but generally speaking, non-latex gloves. Make sure they are medical gloves. Make sure they are medical grade, meant for examinations, meant for the medical industry. You want to have some sort of face covering, especially in COVID right now, a procedural mask, surgical mask. Generally after an earthquake, there's going to be a lot of dust in the air. N95 masks are standard for us to have because we don't want to be breathing in that debris and that dust. And the non-vent is a preferred one for us to have. Goggles, safety glasses, or face shield. When I first took the CERT training, I found it a joke. I was handed a pair of high school chemical goggle or science class goggles. And I thought, I'm not going to wear these. These are dorky. Well, I've talked to firefighters, and LAFD has a policy that anyone who's doing an EMT seeing a patient contact is wearing safety glasses, for the reason that it is very easy for someone who is injured or ill or whatever to spread icky stuff when they talk, when they cough, when you're treating someone, bandaging them. They pull their safety glasses off and there's this sheen of pink or red on it. That's blood. If you didn't have those safety glasses on, those goggles or whatever, that gets in your eye. And now you have possibly a infectious material that has gotten into your body. So the safety glasses are critical to us doing pretty much anything. And again, same thing with the N95 mask. You're out after an earthquake. There's dust in the air. You're not wearing these safety glasses. It's going to get in your eyes and might injure you and take you out of the field because something happened. You know, there was something bigger than dust in there. It caught you in the eye and now you're blinded. Closed-toed shoes, I think this should be self-explanatory. You don't want to be walking around in sandals out there. Long pants, you don't want to brush against something and get cut up. I added this. Perel's done a very good job of pushing hand sanitizer, alcohol-based hand sanitizer. Generally speaking, the medical industry standardizes on BZK wipes. I'm not even going to try and pronounce that. But alcohol dries out the skin. And the training from the Red Cross says that the bloodborne pathogen training says that if you use hand sanitizer, it is because you have no other option to, and you can use it twice. And you're using it as a stopgap until you can wash your hands with soap and water. And you can only use it twice before you must wash your hands with soap and water. I prefer not to use hand sanitizer, alcohol-based hand sanitizer. I prefer hand sanitizing wipes that are made of BZK. It's the same disinfecting wipes that EMTs and paramedics will use to clean injuries. Use these, and they're wipes so you can actually clean your hands with them. If you're using the alcohol-based hand sanitizer gel, you're not cleaning your hands, you're possibly killing whatever's on it, but they're still there on your hands. You're not actually making your hands cleaner. So I like these wipes. They're generally like 5 inches by 9 inches, and you can clean your hands and have a bunch of those on you. Clean your hands frequently. Of course, as soon as you can, wash your hands with soap and water. And if you have the gloves to do so, because maybe you don't, change your gloves between patients and before reaching in for supplies. You don't want to cross-contaminate. You don't want to cross-contaminate your supplies. You don't want to cross-contaminate your team, and you don't want to cross-contaminate your patients. If you have a mass victim incident and you have a handful of gloves and more victims than you have gloves, do what you can with what you have. The hands-on rescuer should double glove. The reason is that it's for your protection. Your gloves are there to protect you from the icky stuff that you're touching, and who knows what it is. What it does is allows you to take off the top layer and put on a new clean top layer. Sometimes you'll find that the top layer has been breached and popped. The second layer is intact. However, sometimes you will find that it will go through both layers, and then you have to swap out both gloves. When you approach from where they can see you and introduce yourself to the survivor. Inform them that you are a member of the disaster response team, community emergency response team, whatever. Spell it out. Don't say, I'm with CERT. They're going to look at you and go, what CERT? Get away from me. You say, I'm a member of the community emergency response team. That is self-explanatory. Or I am first aid trained. Can I help you? Ask them their name. What you're doing is you're assessing here. You're assessing mental acuity. If they give you some weird answer like, I'm Roger Rabbit, maybe something's not right here. Or they just stare at you blankly. Maybe something's not right. Maybe they don't speak your language and they have no idea what you're saying and you're speaking gibberish to them, but they're perfectly coherent. But you're doing this assessment as you're introducing yourself, and you want to establish a rapport with your patient, the person you're working with. Extend your hand to get a handshake. Even for people who don't speak English, it's a common gesture that is well known. You reach out to shake someone's hand, they're going to respond in some way. They might bat it away. They might reach out and shake it. They might stare at you blankly with completely lost eyes. You're assessing their response to you doing something to them. If you ask them during the mental test, what day is it? They might not know what day it is, but they're perfectly fine. Sometimes I don't know what day. A lot of the time, I don't know what day it is. Do you know where you are? Yes. That doesn't tell me anything. Do you know what the address is? Do you know that they know what the address is? I just told you to make sure you know what the address is, because I guarantee that if I ask you where you are right now in the field, half of you won't be able to answer me without looking around. So be careful about the questions you ask when you're testing mental ability. mental cohesiveness. You're assessing their answers and you're looking for abnormal responses. What isn't right, not necessarily what's correct and what's not correct. Ask if you can help them. I'm Patrick, I'm with the Community Emergency Response Team. What's your name? Bob, great to meet you. Extend the hand, get that handshake. Can I help you? You look like you're injured. What's going on? Can I help you? Where does it hurt? What happened? You're establishing that baseline. You're trying to get an understanding because you weren't there when they went down, but obviously they didn't get up and move away when you called for them. Something's going on. You're trying to establish what that is. If they answer verbally, they're breathing. By just introducing yourself, you're able to answer several of the questions about their mental capabilities and some of the parts of the triage. For the hands-off person, you're still going to be wearing gloves because just in case something happens, you have to go hands-on or whatever, but you should avoid going hands-on. You're the hands-off person. You're documenting time, location, name, the information that you're getting, the primary responders getting. You're documenting all of that. If they ask for something or you anticipate they need something from the bag, you're reaching in and getting it for them. And you're reminding your responder, your hands-on responder, to change their gloves after each patient contact that they have. Just because sometimes we don't think about it, especially when our adrenaline's flowing. If you're doing first aid, be it a triage or at a TARP, you're going to be triaging, stabilizing, possibly treating, preparing for transport. When you assess somebody, you want to visually assess them, get an idea of how bad things are. It's called your initial impression. You see that they're breathing, they're having difficulty breathing, they're breathing too fast, they're breathing too slow, their chest is doing abnormal extra work. That's part of the mental picture that you're building in your head of what's going on with that person. We'll go over to the next slide, but the acronym is PENMAN. You're assessing for immediate life threats. What is going to kill this person unless I do something immediately to prevent them from dying? The acronyms are MARCH, RPM, and ABCs. We'll go over that next. When you treat, you're going to first triage the person, find out how bad they are, any life threats, what you're going to do to prevent them from dying immediately, and then what kind of treatment they need. And you're going to constantly be re-triaging. The acronym for that is START. Again, we're going to go over that in the next few slides. And then if you're on the TARP, you're going to be assessing for any missed injuries. You're going to be doing a head-to-toe assessment of this person who is injured. You're going to treat injuries to prevent infection and stabilize them to prevent them from getting worse. You're going to constantly be reevaluating and reassessing your patients because things could change. Someone who's stable right now may not be stable in 5 minutes. And if you don't reassess constantly, you could lose them and not even realize that they had a problem. And then you want to keep in the back of your mind, how is this survivor leaving my care? I can't stay here for days on end treating them. Eventually, they're going to have to either get up on their own and walk away, or most likely they're going to have to be transported to definitive care. And if 911's down and we don't have paramedics coming, how are we going to get this person to the hospital? What are you looking for? The acronym is PENMAN. Every time you're walking up on a possible patient, you're looking around to make sure that you're safe, that your team is safe, personnel and personnel safety. Make sure you're not walking into an environmental hazard. You see a few people laying down with no obvious signs that there's something happened. That should tell you that something invisible there might be waiting for you, and you become a victim if you walk into it. Either they're in a puddle of water and there's an electrical line that's down on it. There's invisible gas that is hovering around them and will kill you if you walk into it as well. So keep an eye on that. Something doesn't feel right, probably isn't. Number of survivors. How many patients do I have? That's critical to know. Do I have 1? Do I have 15? Let somebody know if you have 15 because you're going to need help. If it's just 1, you might be able to handle it on your own, but let somebody know that you're about to work on a patient. Mechanism of injury or nature of illness. Try and develop this picture in your head. Okay, they obviously tripped and fell, scraped their knee. It looks pretty swollen and doesn't look like it's in the right direction that it should be facing. That's probably the mechanism of injury, and I know I'm going to be treating that, but there might be something more. You say somebody is lying there, not moving, possibly not breathing, and you have no idea why, you can start trying to figure that one out real fast. Do I need additional resources to respond? If you have 15 survivors that need your help, you're going to need additional resources to respond. Guaranteed. Do I need outside help? Do I need paramedics? Because I can see right now that this person, I cannot do anything for them other than keep them alive long enough for the paramedics to come and save their life and transport them to definitive care. I want to state that all of this is coming from EMT training. You're getting bits of it. A lot of this is actually coming down to the lay classes as well. So don't feel like you should be learning, you're learning something that you shouldn't be learning. This is all standard training that every EMT gets, and a lot of the lay classes are getting it as well. More advanced first aid, maybe not basic first aid, but this is taught in a lot of the classes now. When you're assessing for life threats, there are 3 acronyms that will help you out with this. I like MARCH: massive hemorrhage, airway, respirations, circulation, and hypothermia. Any of these can kill somebody. I want to treat massive hemorrhage first. If they are spurting blood out of their thigh, I have seconds to treat this and stop that bleeding. They will bleed out within minutes. If something has compromised their airway and they cannot breathe, they will die within minutes, unless I can get their airway open. If they are not breathing, they are dead within minutes if I do not get them to start breathing on their own. If they have a circulation problem, they will die relatively quickly. Depends on how bad that circulation problem is. And it could be that their heart isn't beating, or it could be that they're suffered a trauma and their body is in shock and it's trying to shunt all the blood to their core to keep them alive long enough to survive this. And then if they are not able to regulate their body temperature, they will start to decline very quickly and go into hypothermia. You can cut this down to RPMs or ABCs. RPMs, respiration, perfusion, mental status. Airway, ABCs are airway, breathing, and circulation. They all focus on the same key things. However, coming from the combat lifesaver class, if someone is spurting blood and not breathing, if I take the time to try and get their airway open and they bleed out, they may breathe a few times and then die of lack of blood. So I want to treat that hemorrhage first. I want to put a tourniquet on that injury and see if I can stop them bleeding, and then open their airway and get them breathing again. If I do it out of order, they might not survive. If I do it in the correct order, they may not survive. That's simply the reality of things. But I'm going to treat the massive hemorrhage first. They got a paper cut on their finger and they're not breathing. I'm going to work on the not breathing part because that paper cut's not going to kill them. When you're doing triage, we follow, at least in LA City, we do what is referred to as the START method of triage. Simple triage and rapid treatment. And it's focusing on the 32 can do or RPMs. If they are breathing faster than 30 times a minute, and keep in mind 30 times a minute, that's every 2 seconds. They're breathing too fast. Also, if they're breathing too slow, they're breathing once a minute, there's a problem. Don't count the breaths. Don't go 1, 2, 3, 4, 5. You already know they're breathing too fast. You're assessing, you know what normal breathing should look like. We do it every day. Look at your team members, they're breathing normally. They should be anyway. If you see someone who's not breathing normally, they have a problem. Move on to the next step. Well, actually, just triage them immediate and see if you can do something about that breathing problem. Don't go on to the next step. If the start triage method is a failed test, they failed any step, they are immediate, and they need immediate help because they have something life-threatening going on. They're breathing faster than 30 times a minute, they're immediate. They're breathing slower, they're breathing normally, go on to the next test. You're checking their capillary refill, you're checking for circulation. Is something, if they have massive trauma to their body, their circulation is going to be messed up. They're probably going to go into shock. And if you pinch the fingernail and it doesn't refill within 2 seconds, or you pinch the palm of their hand and it doesn't return a normal color within 2 seconds, something is wrong and they are immediate. Don't even bother going on to the next step. Mark them as immediate. If you pinch their hand or their fingernail and it returns to normal within 2 seconds, move on to the next step now. Can they follow simple directions? What did we say about when you approach? You introduced yourself, you asked them for their name and if they could help you, or if you can help them. You already did the can do here. You already got an idea of how, if they are not responding correctly. So now if you go on to do the can do, it's extra steps. You've already established that baseline as you're walking up. If you're encountering a mass victim incident, don't forget to call out ahead of time. I'm with the Community Emergency Response Team. If you can hear the sound of my voice, come to me. You're shouting this. That will hopefully get people to stand up and walk towards you. You're going to go, okay, I need you guys to go over to the bench. You're visually assessing them as they're passing. Hold on, you look pretty pale. I need you to step back here with me. We're going to see if you're okay. You look like you're able to help me out. Do you mind staying with me? I need a few bodies to help me out here. Everyone else, go over to that bench over there and don't walk away. I need you to watch over everybody. If any of them looks like they have a problem, come find me. But don't let anybody wander away. Keep everybody there. We're going to come back and check on them after we check on everybody else. After the initial triage, re-triage. You're going to be constantly re-triaging because people will go downhill and you won't realize it because they looked fine initially, but they actually have internal bleeding and now they've got a problem that you didn't initially detect. That person who's walking and actually responding, they look pale because they have something going on. You're trying to catch that ahead of time before they become a problem. When you're rating someone for mental status, we use the Avpu Scale, AVPU. You're checking to see if they're alert. If they're fully awake, maybe they're conscious, but they're not fully orientated. They're having trouble tracking. They're just not quite responsive. Verbal, are they alert to a verbal response? Maybe you talk to them and they look at you, but they're not entirely there. Or you're having a fine conversation with them. And they're perfectly responsive to verbal and very cohesive. Sometimes you have to yell at them, hey, hey, hey. And they kind of look at you and then they fade away real fast. That's a stimulus you're providing. Failing that, you can't get them to look at you when you talk at them. Then you're checking to see if they respond to pain. You're going to kind of shrug their shoulder or shake them a little bit, try and get them to respond. Maybe don't try and hurt them and cause them pain, but pinch their finger, do something to try and get a stimulus from them. Sometimes it needs to be a little more forceful, but that's really beyond what I want to talk about here. You're just trying to get that response. If they're not alert, they're not responding to verbal, you're trying to see if at least they respond to some sort of physical stimulus to try and get their attention. And if they fail that, they are unresponsive. And that's bad. When you rate them on the Avpu scale, you're doing a scale out of 4. I'm sorry, this is an alertness scale, not Avpu. Are they alert to time? Do they know what time it is? They're alert to person, place, and event. Do they know their name? Do they know where they are? And do they know what happened? And if you're reporting to an EMT or to the fire department, or you're reporting to 911 and you tell them that they are ANO times 4, alert and orientated times 4, they're alert to time, person, place, and event. That means they're perfectly mentally acute. You say that they are ANO times 3. They don't know what time it is, but they know their name. We think they know their name. They know where they are and what happened. Or worse, ANO times 2, or an ANO times 1, or ANO times 0. They are not responsive. When you're working on a trauma, someone who's just had a really, really bad day for whatever reason, this acronym can help you out. DCAP BTLS, or DCAP bottles. You're looking for deformities. That leg shouldn't be going in that direction. Their forearm should be going forward, not backwards. Their shoulder, it should be lower and to the left, not up and. You're looking for contusions, any kind of bruising, especially severe bruising. I bump into things. I've got bruising all the time, but if I've got an internal injury, it's going to be massively pronounced. Or if I got hit by something, it's going to be a massively pronounced bruising. Abrasions, scrapes. Sometimes these scrapes, they're going to hit the ground and roll. They're going to have debris embedded in their skin, and that, when you're treating them, needs to be debrided. That will lead to infection. But you don't want to, scrape it out aggressively. That's something the surgeons will do. You just want to try and clean it as best as you can, gently get it clean as best as you can. You're looking for punctions or penetrations. Something went into the body from the outside that should not be in there. Obviously bad. Burns, you're looking for, they used to be called first, second, and third degree burns. Superficial is a first degree burn. It's red. It doesn't look great, but doesn't look horrible. Partial thickness, that's when you start to get the blistering. And then full thickness burns, that's where the skin is actually burned away. There's also a fourth degree burn where it's actually burned down the body, down to the bone. That's really bad. They say that third degree burns don't hurt. If you have a third degree burn, it hurts around the burn. Everywhere around the burn is probably a second degree burn. That's going to be extremely painful. But the skin is burned away, and the nerves where the major part of the burn has burned away, that part doesn't hurt. It's everything else around there that has not burned away that hurts bad. So yes, third degree burns hurt. Tenderness, discomfort. You're doing a hands-on assessment of the person. You're touching them, you're palpating, you're watching them to see if they grimace in pain. Some people are very vocal. Oh, that hurt. Other people are used to pain, especially elderly people. They have a lot of pain in their life, and it takes a lot of pain stimulus for them to actually let you know that there's a problem. They don't want to be they don't want to be a burden on people, so they don't talk about their pain anymore because they're in constant pain. What you want to do as you're assessing and you're palpating is you're watching the person's face. If you touch something and they do that, they kind of grimace, they flinch a little bit, but they don't say anything, tenderness. Document it. Let your scribe know, hey, I was palpating the third quadrant of the stomach, the abdomen, and they grimaced in pain. Lacerations. It's a cut. It could be jagged, it could be clean, it could be deep, it could be long and shallow, but that's what you're looking for, any kind of cuts to the body, cuts to the skin. Cuts to the skin means that stuff can get in that's nasty and cause infection. Swelling. All of us probably know what swelling is, but it's basically an abnormal enlargement that could be caused by an injury or infection. If something doesn't look right, it probably isn't. Ask, hey, do you know, are your legs normally swollen like that? Oh yeah, I've got, deep vein nervosis, or I've got, circulation problems. Okay. What about your arm? Oh no, that's new. Okay, document that down. When you're assessing the human body, generally speaking, we're symmetrical. Down the midline of the body, you have one of everything. You have one head, one neck, one chest, one abdomen, one torso. As you move away from the midline of the body, you're going lateral, out to the edges, out to the limbs. You have two of everything: two eyes, two ears, two arms, two legs. If you're expecting two and you find one, might be a problem. If you're expecting one and you find two, might also be a problem. That's more rare. But when you're going to be talking to medical responders, it's good to know the language that they're talking about. And I recommend everybody to at least take a screenshot of this, get an idea. Lateral means away from the body. Medial means towards the core of the body. Distal means away from the heart. Proximal means towards the heart. Those are the key things that you're talking about. And when you're talking about the human body, you're talking about from that person's perspective. So as they're standing upright, like a normal person who's healthy would be standing. When you're talking about the right side, that's their right. You're talking about left, that's their left. Anterior means to the front. Posterior means to the rear. Take a medical class for more information about that. Things get very interesting when you're at a medical treatment area. We're talking about the tarps because we don't do this practice a lot. And even the fire department, it's always very interesting to see them to have to pull the tarps out. I remember watching footage from a crash on the 5 freeway, and they had tarps out. It was, I think, multiple vehicles involved, and they had to, they had so many victims, they had to triage them onto the red, green, and why do I want to say blue? Red, green, and yellow tarps. And that's bad, but it is something that we are going to expect to see after an earthquake. There will be a lot of people who are injured, and triage is the way that we're able to sort them and figure out who is going to die if we don't treat them immediately or get them help immediately, who we can stabilize and not need to worry about right now, and who they're probably fine, but we want to keep an eye on them and make sure that they really are. That's the purpose of triage. So when you break up into a team that's overseeing this, you're going to have a treatment group supervisor who's overseeing everything that's going on at this site. And you want to have this 3-person team I keep going back to: the team leader, the scribe, the radio communicator. Nothing changes here. You want your scribe there because they're documenting everything. The saying is the person with the clipboard's in charge. The person with the clipboard should be the scribe, because I want to be focused on what's going on, and I want to make sure that I'm not stuck in my notes. I'm not stuck on a radio. I'm able to focus and let my team mates, my scribe, my radio operator do their job so that I can focus on keeping everybody safe and making sure that everything is functioning correctly. You're going to be overseeing the 3 tarps: the red, yellow, and green, the immediate, the delayed, and the minor. And maybe you don't even have a green tarp. Maybe you don't have tarps at all. Maybe you've just cordoned off an area and say, okay, this is where we're taking the immediates, this is where we're taking the delayed, and the greens are over there by the bench. The treatment group supervisor is going to be tracking incoming. When they come in, when you have a team that's transporting an injured person in, you're checking and assessing this person and reconfirming their triage. They've already been triaged. They said, hey, we have an immediate victim. We're going to take them over to the red tip. Hold on. What's going on? Tell me what you know about this person. Let's reassess them right now and make sure they are really going to go to the right tarp. Because oftentimes you're going to have someone say, oh yeah, this person's delayed. They didn't get up. They look fine. We're going to take them over to the yellow tarp. Hold on. They are very pale. Let me see something. Yeah, they're burning up. They've got infection. Over to the red tarp. Because eventually they will get over to the red tarp, but you want to get them there in an expedited manner. You're tracking any outgoing. If you have an ambulance that's coming, or you have someone with a pickup truck and they're taking someone out, you want to make sure that you're aware that this person has left the treatment area and where they are going, and whatever information you have about them, name, address, some way that you can track them. Because what if somebody shows up and says, my mother was in this building, is she okay? What's your mother's name? Oh wait, we didn't even document names. We had people who went to 5 different hospitals and we don't know who they are. That's a problem. That's a massive problem. So you're tracking incoming and outgoing. And then you're communicating with staging. Hey, staging, or your radio operator is communicating with staging. Hey, staging, we just had 5 more immediates come in. That's a total of 20 on the red tarp, a total of 15 on the yellow tarp, and 60 on the green tarp. At the tarp itself, you're also going to have a team leader and a scribe. They don't necessarily need a radio, but they're in charge of their tarp. The scribe is documenting, again, making sure that I had 20 come in on the red tarp. There are still 20 on the red tarp. If I see there's 21 and I only have 20 documented, or I think I should have 20 and there's only 19, I have a problem. Maybe someone got up and wandered away and nobody noticed. Maybe that we didn't document that they got transported to the hospital. But something doesn't line up, and we need to remedy that and make sure this doesn't happen again. Again, as they're coming over to the tarp, they're coming in, they get checked. Yeah, they're immediate. You reassess them again. Yep, they look immediate. I need you to put them over there in that open space at the foot of that next person. And if there is a request of status change, you have someone on the yellow tarp and they're getting worse, and they need to get moved over to the red tarp. Team leader is going to go check with the group supervisor and say, hey, we need to transport this person, he's getting worse, over to the immediate tarp. And then that handoff is going to happen. So that there's always communication, everybody knows what's going on, and everything gets documented correctly. This is how I would lay out my tarps. I've seen it done different ways. But if I'm the group supervisor, I want to be able to watch the red tarp. I want to be able to see the delayed tarp, the yellow tarp, and I want to have some sort of less priority visualization of the green tarp. I want to be able to focus and say, if something is going wrong, hey, they just don't have enough people on the red tarp, or hey, they're moving too slow, there's people who haven't been seen. I want to have that visualization and hopefully get additional resources over to remedy the issue. But I also want to be an extra set of eyes. Hey, that person's getting up and wandering away. Somebody go stop that person and make sure that they don't wander away. And that happens with mental issues. As someone who's in shock doesn't realize there's a problem, they might get up and wander away. Something's going wrong, and going wrong fast, and it's horrible to lose a patient because they got up and walked away. It's just as bad to lose someone the other way too. Again, you're going to have the tarp leader and the scribe probably at the head of the tarp, just keeping an eye, and then you're going to have first aid pairs on the tarp itself actually doing the first aid. You want to position yourself in a way that incoming has to go through you if you're the group supervisor. You don't want to have them coming in from 5 different directions. That is a recipe for losing victims or having people not get checked in correctly. So if you're in a way you can situate it, having your back to the incident and having only one way, they have to go past you so that you can see them as they're approaching, that's ideal. Every situation is going to be different. The first aid pairs on the tarp. They're going to re-triage as soon as somebody gets there. They're going to confirm that they're correctly triaged, red, yellow, or green. They're going to assess and reassess. They're looking for the life threats, the killers, ABCs, airway, breathing, circulation. They're going to be checking every 5 minutes if they're unstable, every 15 minutes if they're stable. That is standard. When they can, they're going to do a detailed assessment that is a head to toe. You're looking for things that might have gotten missed during the original assessment. Yes, they came in because they got a severe burn, 3rd-degree burn, and they're in shock. But what you didn't catch during the original assessment, the original triage, was they also have an exit wound. They got shot too. Now you have 2 injuries. And unless you do that head to toe, you're going to miss that, because for whatever reason, you want to make sure that you're fully aware of what's going on with this person. I restate, 1 person hands on, 1 person hands off. You're not cross-contaminating. You're having someone who's documenting that's not getting blood on them, and they're reaching into the bag and not contaminating your bag and handing you what you need. And plus, they're able to be an extra set of eyes and a sounding board for you. We don't do this for a living, so having additional help is going to be vital. Again, it's based on the number of resources you have. This is ideal. If we had all the resources in the world, this is how we would do it. You're going to do the best you can with what you have. Typical interventions at the TARP. We are going to organize your survivors head to toe, head to toe, head to toe as they're laying there on the TARP. That allows you to go from one person to the next person, the next person. Additionally, people who are in trauma or severely injured tend to vomit. It is a reality. You don't want someone head to head with someone who's vomiting, because then you will have 2 people vomiting. Then you will have 3, then you will have 4, then you will have a lot of people vomiting. Head to toe, head to toe, head to toe. It allows a workflow. You're assessing, doing literally a head to toe assessment on somebody, and you start at their head, you move down to their feet, and then you're at the head of the next person. You again, head to toe, you're at the head of the next person. It's just good workflow management. Also, stops cascade of vomit. Well, reduces. Plus, if someone's moaning and groaning and coughing and spitting up stuff, you generally don't want your head next to them anyway, if you're already having a bad day yourself. You're going to be treating bleeding. Direct pressure. If you realize that direct pressure is not going to be enough, advance to a pressure bandage if you have them. If that's not enough, go to a tourniquet if it's appropriate to put a tourniquet on. If someone's bleeding from their chest, you're not going to be able to put a tourniquet on. If they're bleeding from their neck, you're not going to put a tourniquet on it. Generally, it's going to be a limb. Otherwise, do the best you can. Sprains, strains, dislocations, fractures, there's nothing we can do that at our training. You're going to splint in place to try and stabilize the injury and hope that they can get to definitive care where they can do something about that before it causes a problem, permanent problem. Before and after you splint, you're going to check for color, motor function, temperature, and sensation, CMTS. Make sure that they have a pulse, that they can feel your touch, and that their skin is warm and dry. If you apply the splint and they no longer have a pulse below where you put the splint, you put it on too tight, loosen it up, recheck. If they were able to feel you before you put the splint on, and then after they can't feel you, you put it on too tight, loosen it up, and reassess. Open fractures, there's bone sticking out. There's not too much you can do about that. You're going to cover it with a dry, sterile dressing and hope you can get them to definitive care very quickly. The dry, sterile dressing is to try and reduce the chances of anything getting into that injury and causing infection. They already have a bone sticking out. It's bad. Someone is in shock. Most people who go through a severe trauma will go into shock. It is simply the body's way of coping with it and trying to keep them alive. So you want to lay them flat. You want to keep them covered and warm. and you're going to raise their feet just to try and promote blood flow back to the head. That one's a little iffy on standard on the current training, but that's what CERT teaches, so you're going to continue doing that. You want to maintain a patent or open airway. If they stop breathing on you, that's a problem. They don't breathe for very long, for more than a couple of minutes, they're dead. There's no recovery for that one. So there's been incidents where there's a mass victim incident, they're assessing, they're leaving someone on their back, and they vomit, and they can't clear their airway, and they die. So what we prefer is that you put them in the recovered position. If they do not have a head or neck injury or suspected head or neck injury, the recovery position, you're going to roll them onto their side, stabilized by their arm and leg, and this way that their body is kind of in a position so that it can be stable and not roll. But if they vomit, they're going to vomit out and it will clear itself. When you hand off to definitive care, either hopefully paramedics or an ambulance or someone is taking them in the back of a flatbed truck to a hospital, you want to communicate, if you know their name, communicate their name, never over the radio, but when you hand off in person, patient name, age, sex, time they arrived, chief complaint, and any treatments or interventions you have performed. Yeah, we bandaged them. They have an impaled object in their arm, and we bandaged around it to stabilize it. However, we did leave the edges of the penetrating item visible so that you know it's there. We put a tourniquet on this person. It is on their lower left arm. Then you're going to report the transport to staging so they know that they have an updated count and where that person is going. So these are getting recorded. This is live streaming to YouTube. You can visit our channel at videos.ntp-la.org to see our previous trainings. We are severely backlogged in editing, but we'll get there eventually. Our upcoming trainings are available at calendar.ntp-la.org. I don't know that we're going to have a radio training this month. I'm sorry, this is October. We will have a radio training this month. I don't know that we will have one in November or December, simply because of holidays. And then if you're interested in signing up for our newsletter, you can go to join.ntp-la.org. My contact information, you can reach me at LAFD Cert Central at mycertteam.org. Visit the LAFD Cert website at cert-la.com. Any questions?
I have a question, Patrick.
Yeah, Johnny.
That's good information that you put out for everybody. Every training is always different, and everything what everybody else says. I mean, what you're saying and all that, all this training, we know it's going through the same procedure and all that, but every training is all different. Thank you very much for your good help. And we are supporting this. We are still trying to work on getting the containers for El Sereno, the ones we donated 5,000 from the neighborhood council. I am still working on that, Patrick. We're still working. I know at times consuming because of COVID virus and all this stuff, but very good information, Patrick. Good job. I'm proud of you.
Thank you, Johnny.
You're welcome.
Do we have anyone from LAFD on? Captain Gross, Captain Gates, a bunch of anonymous people. If you can do me a favor and mouse, if you're showing up as anonymous, please mouse over your square, hit the ... and then hit rename and put your name in.
I have a question.
Yes.
So I would probably try to be the scribe because, I'm getting older and I don't have the energy to run around and rescue people. But I'm, I can take notes. And but I got this sense that the scribe needs to be everywhere. I mean, I got like, there's the tarp, and then there's the triage area, and then there's so is there just one scribe, and can one scribe do all that, or how does that work?
No, you need multiple scribes. This
Yeah.
is why it is a critical position and should never be looked down upon to think, oh, they're just the scribe. They're that critical. If you have scribes everywhere, good scribes, you're going to do so much better. But that's why we talk about the leadership team being the team leader, the radio operator, and the scribe, because that is the core group. And there's going to be multiple of these core groups. At the tarps, you're going to have the tarp supervisor, their scribe and radio operator. And then at each tarp, there's going to be the tarp leader and a scribe. And then when you have the hands-on people, the hands-on person, and then their hands-off person is also a scribe. So you're going to need a lot of scribes.
Uh-huh. And how are these positions assigned? I mean, the other thing I'm kind of confused about is I don't know what group I'm with. I think I'm with Lamar Park, or how do I know what group that I am with?
If
I just started
you're in
training.
South Bureau, you want to reach out to Chin, who is the South Bureau coordinator. I don't know if he's on with you, and then he's going to help you find out where your affiliation is. Also, if you go to join.ntp-la.org, part of it will be you can look up your address, and it's going to tell you your fire station first in, and that
Yeah.
will help us in finding out where you are.
Okay, yeah, because I'm about a couple of blocks from a local fire station.
Judy.
Okay, so where do I go to find that out?
So I'll put it in the chat again. It is join.ntp-la.org.
Okay.
All right, Judy.
Outstanding, but a whole lot of information if you haven't heard it before. What would you recommend for each one of the leaders here, or anybody who wants to be a leader in their community, for learning and review? Because a lot of their neighbors are not going to know it. And the review part is getting it entrenched in your brain, some of the mnemonics and all of that. So what do you think?
We're going to be doing monthly drills that are going to be focused on particular skills so that we can rehearse this a lot. If you just do it once every 2 years, it's not going to be enough. This is something that needs to be practiced. We're going to try and give as many opportunities as we can to do this, especially as COVID restrictions hopefully start to lift and we can start really training in person again. This is something that will be a major focus of our efforts. I wish I could give a better answer than that.
No, that's perfect. Thank you. I just wanted everybody to feel like if they're overwhelmed, that there's going to be some answers, resources and practice that is coming up. That I think is important for people to know, it seems.
Could you give me that address again? I had to grab a pen, so I didn't catch it all.
It's in the chat, join.ntp-la.org. N as in neighborhood, T as in team, P as in program, -LA as in Los Angeles.org.
Okay, great, thanks.
There's a question about not broadcasting the individual's name over the radio. And is it ever appropriate to give a name? No, I can't think of any reason why you would give a name over the radio. I would strongly recommend that you don't even address your fellow rescuers and members by their first name. If you listen to the professionals who do this for a living, everyone has a call sign. And so you want to establish a call signs ahead of time. We're using call signs in LA City on the volunteer side, but you're near Sherman Oaks. You're Eureka. So figure out a call sign system up there and then stick to that and practice using the call signs. Judy.
Yeah, sorry about this. I just thought of something else that might be important. Diane was asking about scribes, and we've got a whole lot of activity involved with scribes. But maybe you could just mention really quick, what forms do scribes use? Do they use a blank sheet of paper? Does it have to be blue ink? I mean, what do they do? Where are they writing?
Form 0 is a blank sheet of paper, either a notebook or just plain paper. You do what you can with what you have. If you have the cert forms, there you can download them from cert-la.com. You can search for cert forms, community emergency response team forms on the internet, and you can probably find them. They're designed to kind of push you in the right direction and form along the response chain as you need them. Some of them are not going to be entirely useful. Others are going to be something that you're using a lot. We'll do a training on forms again, specifically on each form. But in general, have blank paper, have a blank notebook, just so that you can write down something, because you never know when you're going to need to write something down.
And clipboards.
And clipboards, yes. There's a question about stepping on glass and debris and bare feet. If you're treating, you're going to try and debride, remove the glass, remove the debris, gravel, whatever. If you have sterile saline solution and can try and flush it, that's ideal. You don't want to necessarily be going in and picking things out. It's a wound care issue, and it's not something really we're going to talk about here. It's a lot more. Take a first aid class, ask them about, or a more in-depth first aid class. You're probably not going to cover it in basic first aid, but if you take an emergency medical responder class or wilderness first aid class, ask them about cleaning injuries. Any additional questions?
Daryl, has a question.
Well, it looks like there's a question about the placement of the black tarp.
Yes. So the black tarp is going to be away from the rest of the tarps. You want it in a secured location. You want to have somebody there just to make sure that nobody gets up and walks away who's been deemed black tagged. It has happened. It's not a zombie apocalypse thing. It is simply that somebody got triaged incorrectly, or whatever. They were not giving enough signs of being alive, and somehow they ended up on the black tarp, and then they got better. And they're going, I am on the black tarp. Also, it is to prevent looting, because if you leave people who have passed away and there are desperate people out there, their belongings that are still on them will get pilfered, and it is sad. You don't want it right next to the rest of your tarps, because you don't want your already traumatized victim looking over and going, that's a dead body. Oh my God, what happened to his face? Also, during an exercise, I was being transported, and they said something about black tag or something like that, and it's not something you want to talk about in front of people who have had trauma and might be aware what black tagging means. If you tell somebody that they're getting black tagged, they're going to freak out. Yes, they may have a gaping hole in their chest and they will not survive, but they're still conscious and they're still looking at you, and you're telling them that they're about to die. That's probably one of the worst things you can do to somebody, right minutes before, seconds before they actually do. So be very careful and cognizant about that, especially in the people who are not getting black tagged but suddenly think they are. Don't do that to them. Does that answer your question, Daryl? All right. Is Chin on here? So many anonymous people. I don't know what we got here. Any other questions?
I have a question.
Yeah, Johnny.
That's what is name? Dina Lorenz. She's up in Eureka.
Yeah.
Oh, I'll be going up there in about 3 years. My granddaughter's up there. I'm gonna start a new search program over there. I'll be going up there. I'm already retired. So when I see you up there, we got to get in touch and make a big search. We can do a lot of things when I go up there. We're talking about 3 years, not right now. I still got to handle with Patrick and doing the stuff in El Sereno. But I'll see you in 3 years. I'll be up there. Time to retire. With all respect to everybody, let's keep search going. Patrick, good job what you're doing. And all these people that got to know what's going on, the training first. See what you're going to do. See how you're going to do this thing, because people get in shock. I've been in the military 12 years. And I could say by my personal thing, what we're doing, yes, there's going to be disasters. Just like you say, people get up, they go up, there's a big earth, they start running to get their kids. Yes, you're right around, Patrick. And they get cut up by their feet. They don't know. The first thing they're going to is protect their kids. That's the one thing. But that one lady in Eureka, I'll see you in 3 years. We're going to build it out. For my granddaughter. Thank you very much. That's all I have to say.
Thanks, Johnny. There was a question about Frs Radios. We are currently testing radios across the city of Los Angeles, so we can actually make a recommendation. We're hoping to have one in November and be able to actually publish it and make that recommendation. At this point, I can only say read reviews online. Don't buy the cheapest. You don't need to buy the most expensive. But see what other people have done. And then when we publish those findings, we'll let everybody know who's on our email list. Yes, medical training. Like I said, we're going to be doing it. So I recommend everybody take a basic first aid CPR AED class at the very least. Make sure you're current on that. That's every 2 years. Try and take a more advanced class. Wilderness first aid is going to be very similar to what we're going to see after an earthquake. When we don't have power, we don't have definitive care within 5 minutes of a 911 call. And then if you can take a more advanced class like emergency medical responder or EMT, the general progression I recommend is we take something like wilderness first aid first, skip the 8-hour basic first aid CPR class, go directly into a more advanced class, then step up to emergency medical responder, and then step up to EMT. And that progression is going to make it so that you're not getting overwhelmed. Taking an EMT class is challenging, and if you're going in cold, it's difficult to pass on your first attempt. In fact, some community colleges will actually require you to do the emergency medical responder class first, because they find that if you take EMR and then you go to EMT, it's about 80% review. That's how good the EMR class is. We do have some first aid classes that are happening in South Bureau right now. They're starting this weekend. If you're on our list, you should see our events. If you go to calendar.ntp-la.org, again, I'll put it in the chat. It's going to have all of the stuff that we have advertised. And we're not teaching it ourselves. We're bringing in training providers to do this training. And as soon as we can get an EMR class up and running, we'll let everybody know about that as well. So are the Dodgers winning yet?
You do not want to know.
I can keep myself distracted for a little bit longer, but I'd imagine
The
that.
Dodgers are winning.
Do not watch the game
Oh,
if you're a
geez.
Dodger
Okay, I'm
fan.
going to put myself in mute. Sorry.
Okay. Thanks from Eureka. Way to dash my hopes. What inning? There's still a chance. Oh, jeez.
There's no chance. It's the bottom of the
It's the
ninth.
ninth inning, bottom of ninth.
No chance. Sorry, fans. Not happening.
Well, as we say with the Dodgers often, next year. All right. Graphic up again about the info about the recording. If you search our YouTube channel, just search for LAFD CERT, you're going to find the LAFD CERT coordinators or LAFD CERT continuing education channel. You can also go to videos.ntp-la.org, and that'll link you to our YouTube channel. All right. If there's no other questions, then I don't feel a need to keep you here captive
Yay.
longer. So have a good night, everybody. If you do need to reach out to me, you have any questions, feel free to email me at lafdcertcentral@mycertteam.com.
Yep.
And everybody have
Keep
a
up
good
the
night.
good work, Patrick. Keep up
And-
the good work. I'm proud of you.
Thanks, Johnny.
Bye,
I gotta-
everybody. Happy
I gotta learn
Halloween.
more.
Bye-bye, thanks.
I think the Dodgers are losing. We don't have no
What do you
chance.
think? Oh,
I'm gonna take myself. I'm gonna mute myself.
All right. Have a good night, Johnny.
All right, everybody. Good. God bless everybody.